Welcome to another episode of the Blessing Health System podcast. Today's guest is Dr. Sean Moroze. Dr. Moroze is an orthopedic surgeon here at Blessing, and he's also a United States Air Force veteran. To start out today, I was kind of curious, what got you into medicine? Like, where did you see that passion start to come from?
Yeah, I think for some degree that I always wanted to be a physician, right? And I say that, and I just remember ever since I was a kid, like that was going to be this is what you do, this is where you're going to go. And in undergrad, I went to a small private Jesuit school in Denver, and it was, I was looking for good education, right? So good class sizes. I don't want to be in a class with 450 of my closest friends. I think that to me, from a learning standpoint, just wasn't going to work for me. And so, in undergrad, smaller university, you get to know the professors a little bit more. You get opportunities to be in different, groups and organizations, and starting there in undergrad, and really getting involved in the sciences and then also volunteering, because the Jesuits were really big into volunteering. And so, some of the leadership started there, in terms of some of the honor societies, that kind of thing. And then, of course, the goal is always med school. So, after applying to med school, and I applied a year earlier than normal, and that was on purpose. So the first 2 years of my college life were not very fun. But I wanted to get ahead of it and get applications to med school and pretty early, and get out there and not be, because a lot of times you get a lot of classwork, and then you're studying for the MCAT, and then you're applying to medical schools, and it's all within like a several month time frame. But I did it a year early, so I had more leeway. But then I go into undergrad or to Loyola Chicago for medical school. Again, another Jesuit school, right? So my mom, I went to Jesuit education, and she's all about it. My uncle was. Yeah, exactly. So then, there it gave me an opportunity as well to go down to Guatemala after my first year and do some medical mission work down there for 2 weeks. And in med school, you're not, there's no like, here's the orthopedic surgeon track, here's the family medicine track. It's kind of like everybody does the same thing for the first 2-3 years, and then you get a little bit more, freedom your last year to pick things you really want to go into or that you're going to apply to for residency. So we go down there to Guatemala, and you're really just doing primary care. But the things you see down there are just, you don't have a good idea until you actually go to a third world country, or less developed than us and some of the other European countries that don't have good health care.
What kind of things would you, like, what was like a typical day like over there?
Yeah, so we stayed in a little town called San Lucas Toliman, and it was one of the towns around one of the larger lakes down there. And that, everybody, as with most of civilization, you kind of they form around bodies of water, right? So a lot of these small towns are around this large lake, which served as the primary economic focal point, for fishing and sustenance. And so we were in one of the small towns, and then every day we'd get in some trucks, some little pickup trucks. We had a translator with us, and we'd go out to these more rural communities. We'd set up shop. We had a pretty meager, medication bag. We had general like Tylenol. Yeah, exactly. So nothing too intense, because part of it is you can't just go down there and do all this advanced medicine and care if you don't have the follow up, right? So you got to be kind of careful that you're not doing something that would need a lot of follow-up, and then these people don't get follow-up, and then they're worse off than they were, right? So, but a lot of it was education. A lot of it was, educating the residents, and then taking care of what we could based on what we had. I mean, as simple as like one time we were, some young boy, probably 8 or 9, came in and with his mom, and he was complaining of ear pain, and you take an otoscope, the thing the doctor always looks in your ear with, and there was a spider in there, like just setting up shop, So obviously get rid of the spider, clean it out, and the boy is going to feel much better. So those are kind of things, like, you're not going to really see that in America, right? I mean, maybe in some small pockets, but generally not. And so things like that, you can make it, a huge difference for something that's relatively easy, even for like a medical student to do. And then there was one time where a patient had, a bad injury and she needed, actual medical care, but they don't have the money, right? They don't have the ability to go to, get the bus fare to go to a larger city, go to a larger hospital that has, for orthopedic care, for instance, that this lady needed. And so we actually, between the other students and then our physician attendings that came with us, like pulled together some money for a bus fare and to go to the hospital. Now, whether or not she ever went, who knows, right? Because then they see all, they just got money, and then she's like, well, I actually need to like feed my kids, or something like
you do
that.
What you can do, yeah.
Yeah, exactly. So
yeah, how did we go from, pulling spiders out of kids' ears into orthopedics? What sparked that? Was it that trip to Guatemala, to some of the stuff you saw? Like, did you find yourself gravitating towards those types of things interested you more? Or?
A little bit. I did have a family friend who I shadowed in college. That was an orthopedic surgeon, and really enjoyed hanging out with him and learning from him. And our families were friends, and just from a mentor's perspective, that was one of my earliest forays into medicine, was the orthopedic side. Now, again, orthopedics is competitive. So there's a lot of kids that come into med school saying I was an athlete, I had ACL injuries, or so I'm going to be an orthopedic surgeon because I, was around orthopedic surgeons as an athlete or being injured myself. And so, but it's hard to get into. So you have to perform well in med school to start with. And so I didn't really, to be fair, I went into med school wanting to do pediatrics. And because I love kids, I was a kid swim coach. But then I did my pediatrics rotation, which is required in every medical school as part of the core rotations. And I mean, to be quite honest, I was a little bored, right? And I say that with a sister who's a pediatrician and another sister who's a neonatologist, who's the baby ICU doctor, but she has to do pediatrics for 3 years before even that fellowship. So essentially 2 sisters who are pediatricians. I love pediatricians. I think they're great, and it's a special person to do what they do, but it just wasn't for me, being in clinic all day and, the same thing. And so, but then I spent time with the orthopedic surgeons, and it was like a different thing every day. We take care of trauma. The orthopedic trauma can be quite interesting. Spent a lot of time on the total joint service in medical school and really loved that. And of course we have to do clinic, right? We have to see patients in clinic because that's how we sign up the patients for surgery, but also follow up the patients that we did operate on or who we're treating conservatively. So there is that part of it, but those surgical days, there's always something different. It's fun, getting your hands and being active. And then, of course, the trauma side of it is it can be a bear sometimes because you never know how busy your night will be. But having done the peds rotation, being like, oh, this is maybe not for me. Right. And then doing the orthopedics rotation and kind of really enjoying it from a culture standpoint, from a surgery standpoint, and just a schedule standpoint, I really gravitated towards that. And then, of course, through my coursework, I excelled and was able to fortunately apply to that residency.
So do you remember what that first surgery was like? And at what point did you do that first surgery? Was it after the med school, through residency, or?
Yeah, I mean, so it happens in residency, right? So you do med school, and surgeons in med school will let you, maybe close the wound, suture up some things, maybe hold a saw if you're lucky. But, residency is where you really cut your teeth, and it's essentially like an apprenticeship. You learn under guys who've been doing it for a while, and they slowly give you more autonomy. And so, yeah, I mean, it's the second year of residency. I remember my first case, and of course there's, nerves and, anxiety about it. And, as a swimmer, you were always told, like, you want some nerves, right? You want some anxiety because, otherwise, you may not perform as well as you hope.
Makes you sharp.
Yeah, exactly. So you kind of expect that, and then you just prepare, right? So that the case is coming, what's going to be expected of you. And so that kind of helps allay some of the fear. But, it is still, you're operating on someone putting their life in your hands. Of course, if we're doing a total joint replacement, it's an elective procedure. It's not an emergency procedure, something like that. but still, and it was it was fun. It was exciting. And then, of course, after you do the surgery, you're like, high-fiving yourself and your colleagues, like, yes, I did it. Everything went well. But then comes all the stuff after it, right? You want to make sure they do well, they don't have any complications. So then you have that extra anxiety on top of that, that everything you did was appropriate and the x-rays look good. And, so I remember all of that very vividly as a second year, just starting off, 2 years into a 5-year residency program. And then by the time you're a chief resident, been there for 5 years, you're doing most of the cases yourself. The attending's in the room, but they're, basically the knife is in your hands, just trying to get those reps. And so there's still, like, even to this day, you get some butterflies going into these cases, but now there's a lot more muscle memory and experience, so you don't get quite as nervous.
Mm-hmm. Yeah, that has to be like a big. Even like if you looking back on that first one now, it has to be just such a different feeling, getting
right.
in there now.
Yeah, you think about it as like, if I knew then what I know now, like, wouldn't have been nearly as nerve-wracking, or but clearly that's not the case, right? So, as a little junior resident, you're just happy to be doing surgery and finally getting your hands dirty. But of course, I wouldn't be where I am today without all those little baby steps up and till this point. It was fun. Memory I'll never forget, obviously.
So with your experience in the United States Air Force, did you see any like military injuries while you were there? Like, was there anything that you saw that is maybe different in nature to like a civilian injury? That's something you see now?
Yeah. So, good point. Yeah, good question. They, the Air Force paid for my med school as part of their scholarship program, and then when you apply to residency, the Air Force, that was the only place to do an Air Force residency, and then you had the option to do civilian. But the Air Force picked me to go to their residency. So down in San Antonio. So Brooke Army Medical Center is a combined Army Air Force area. Lackland Air Force Base is down there too, big Air Force Base, and so there's a lot of Air Force Army. And when you look at the time frame I was there, was 2014 to 2019. So we were still in Iraq and Afghanistan at that point. Some of the fighting had died down quite a bit, but we would still see, the way it would work is that they would get injured over there, obviously, and then they'd get stabilized in theater, and then oftentimes sent to Germany, Landstuhl, where they could potentially get more surgery. But then the definitive surgeries would either come to us or Walter Reed on the East Coast. And so we wouldn't see acute injuries from the war, but we would see the blast injuries that had been washed out a couple times. They'd have some special dressings on, but are needing the definitive treatment. And so we saw a lot of that. We saw a lot of the rehab side of those wounded soldiers, a lot of amputations, eventually post-traumatic problems that would occur, whether that's post-traumatic arthritis or the fractures weren't healing or the hardware was failing that was placed either overseas in theater or in Landstuhl. The guys we treat over there, it certainly would give you a new perspective. People always thank me for my service as a Air Force physician, but what I did pales in comparison to what a lot of the other guys and gals were sacrificing, right? And I basically signed up for the Air Force, and the Air Force paid me to do the job that I'd wanted to do since I was 5, right? A lot of these people, would sign up for the Air Force or the Army or the Navy, and they're not quite sure where they would be sent, and then before they know it, they're overseas, they're infantry, and they're sacrificing a whole heck of a lot more than I was. And so I was just grateful to be able to take care of them and with my colleagues. And like I said, the guys before me in residency, they saw a lot more of those injuries than I did, because thankfully some of the war was starting to wind down by the time I was there. But I do think from the standpoint of experience, when you're in residency, the whole goal is to see and do as much as possible so that when you get out, nothing surprises you. You're competent and you're confident. So from that end of things, having those kind of injuries and having to do, certain types of surgeries that, to your point, like our civilian counterparts, they're not, thankfully seeing a lot of blast injuries and you know what I mean? So You know, in the rare exception, you know, think Boston Marathon bombing and things like that, where, you know, you get pretty similar to what we would see on a battlefield. But yeah, my civilian counterparts generally wouldn't see a lot of the explosive related injuries that we would see and take care of down in San Antonio. So from that end, it was a great experience to kind of gain that knowledge and those skills. And then you're learning from guys, you know, from these attending Army and Air Force surgeons who'd been doing it for a while. Some of them had been there during the thick of the Afghanistan and Iraq wars, and had even deployed, you know, because they'll deploy to theater and treat them acutely. They would be the guys seeing them right off the battlefield. And so, you know, they had just an incredible and immense amount of knowledge and being able to pass that on to us. So we, you know, like I said, I hope we never are in another war, right? And we're not really seeing those injuries again, but those odds aren't very likely, you know, just given history. So I'm grateful that I had that opportunity, and I'm grateful for all the men and women who have sacrificed so much for our country, and I was able to take care of them. But my Air Force, you know, the medical side of the military is much different than, you know, the line officers, and, you know, the medical side gets a little, we're more protected. We got, you know, kind of somewhat different hierarchy, you know, and so it was still a great experience to be able to treat them and be involved.
Did you get to learn to fly at least?
No, no. So interestingly, you know, so when I was stationed at Eglin as an attending surgeon, we had the F-22s and F-35s there, and you know, I knew a couple of the F-35 pilots, and so I always wanted to go up, but then you hear these stories of these other non-pilots going up in some of these jets, and not even the 35s and 22s, just some of the older, you know, variations like the F-15s, and I mean, it's not easy. I mean, what those pilots have to go through, right? Like the G-forces. Yeah, exactly. And so not all of the people that got, you know, were able to fly would recommend it again with some of those guys. But and then when I was deployed to Qatar, and I was treating some of the heavies, you know, the guys that fly the tankers and the cargo planes, and they wanted to take me up. And the tankers fly, you know, they'll do like 8-hour sorties. They'll just, you know, they're up there for a while, and then but the hospital command didn't want me as their only orthopedic surgeon, like up in the air for 8 hours, and they couldn't contact me if they needed me. I mean, odds are nothing was going to happen, but you know, so there's a lot of like regulations you got to go through as an Air Force, you know, physician in order to get up in a plane. And they certainly don't want to put you into a lot of harm's way, because they just spent all this money training you and educating you that they want to kind of keep their assets available. Yeah. so unfortunately, no. But it would have been a fun time if I was able to.
Yeah. So some of your specialty now is replacing joint replacements that have, you know, worn down or failed. Do you think that your time in residency, like seeing those patients that were, you know, treated acutely, sent to Germany, and then sent to you for that final review, does that go into your specialty now at all?
I mean, we did a lot of joint replacements, but you know, the redoing the ones that have failed is a very specific and technically challenging field. And so, you know, there's certain areas of the country and certain, you know, medical centers that will see more than others just because of the volume. But ours was not one of those centers that saw a lot. And I mean, of course, a lot of our active duty population ends up with arthritic joints, right? Painful joints, right? Because they have very active jobs, or especially the guys that jump out of airplanes, right? Like, I mean, yeah, like down the road they're going to have arthritis. So we do see it. We saw a lot of the primary joints, but the revisions we didn't necessarily see. But you know, that to me is like the more interesting side of total joint replacements, just because they're so different. You know, every patient's a little bit different, and there's so many things you have to consider and think about. And that was the reason for the fellowship, you know, so doing an extra year of one of those high volume centers that would just, you know, see a lot of those revisions, see a lot of those patients who need a redo, and get a lot of that experience.
So is it like each individual patient? I mean, I could see with how interested you are in it, like getting kind of lost and like trying to figure out each, like, why is this behaving this way? Why is this guy behaving this way? What's the difference? Does that kind of go into like your motivation for furthering education? Like you recently got that master in healthcare administration. So is that like part of it? Is it just a pure love for it, or how do you find that motivation to just keep furthering your education?
It's one of those things where you got to find that sweet spot, right? You can just do education all day long and get all these kinds of certificates and diplomas, but at the end of the day, you got to put it to good use and put it into practice. And I mean, for revision joints, you can certainly go down a rabbit hole and be lost in like all of these, angles and implants and, lab studies and aspiration results. And, there's tons of data being published all the time from these giant, medical centers that see a huge volume, and you can get lost in the articles. And so you really have to be, I wouldn't say dogmatic, but more of like from an algorithmic approach. Otherwise, you'll just spend all day staring at x-rays and lab values and not treating patients. And then, to your point, I did get a master's in healthcare administration. That was while I was in the Air Force. Kind of started that during COVID because we were shut down and couldn't do anything. So I thought, I might as well do something productive since I can't do surgery right now. And that was helpful from the standpoint of learning more about the healthcare system, how the other side that physicians don't always see, how that side works, that administrative side. And I do think that plays into the revision and the total joint population because, there is for as much as we want to be able to control what happens to the patient as physicians, we are still at the mercy of insurance companies and hospitals and, in network or out of network and insurance plans. So, it definitely brought more light into that. And I think just my personality in general too enjoys just constantly learning. And like, I find joy in that. I know some people are like, oh man, I couldn't wait to get out of school, but it's not something I want to like keep getting masters and keep getting other, degrees, but I just enjoy learning new things. And the more educated you are in a variety of topics, I think, then you start being able to pull from that other knowledge base, and it can help me understand why, certain joints are getting infected, or why this patient didn't do as well, perhaps, just because I, read some extra stuff or learned some extra things about topics that some people wouldn't consider important or necessary. And I think a lot of times in medicine, and certainly as subspecialists, we like get into our little silos. We just think within our own. Like I'm just a total joint surgeon and an adult reconstruction surgeon. I'm only going to think about that. But then we fail to realize that all these other subspecialties, all these other scientists are publishing data that could help inform what we're doing. And I think too much of medicine is actually in a silo. You start to learn a lot more, and you see what other specialists are doing and how they're treating things. And I think there's a lot that can be applied to your specialty too. So I think that thirst for knowledge and learning kind of helps with my patient care and outcomes.
Mm-hmm. Is there anything new that you've read, journals, anything like that gets you excited for the future of joint replacements, whether that be new technology, robotics? Like what kind of gets you excited about it?
Yeah, so there's a lot of talk right now about robotics, right? So you see that, and I'm trained in a lot of the robots, right? I used a lot of them in fellowship and as an attending orthopedic surgeon for the Air Force, and so, but like right now I don't use them, and right now the robotics doesn't really get me excited. I know patients come in talking about it a lot, and I think if used for the right purposes, they can be really, really helpful. But I think a lot of surgeons lean on them, basically as a crutch to perform a good surgery. And, for me, that's not necessarily what I would need them for. They're good for some deformities, and if they've had previous surgery and have a bunch of hardware in there already, and maybe the robots can help you avoid some of that hardware and do a good total knee or total hip. But
is it precision? Is that what it
is? Yeah, exactly. It limits the outliers, right? So we try to put these joints in a certain way that they're going to be functional and pain free. And so you kind of want to match them to the anatomy. And so the robots are just better at matching them to the anatomy. But the difference is that no studies have shown significantly that they've improved patient outcomes. And so it's not like the patients are doing significantly better. But, I think with time, like technology is always going to win, right? It's always going to progress. It's always going to get better. And so, I use AI, like hip navigation in my total hips. So there's a portion of that technology there. I think one of the cool things coming out recently and what remains the biggest issue in total joint world is periprosthetic joint infection. So you do a total joint and gets infected. It's a bad problem just because you've got all this metal and plastic in your knee or hip, and now you've got bacteria on it. They form this biofilm, and then your body can't fight it, and it causes infection, pain, swelling, difficulty, with daily activities. And so, working that up and kind of being able to diagnose it is still a little bit challenging. There's a lot of debate on that. It's labs, it's imaging. Sometimes we take fluid off the knee and send it to the lab to evaluate it. But even then, even if you do all of that, you don't catch all the infections, or some of them look infected and you get in there, it's not infected or something of the sort. And so the real thing going forward in total joints and what's exciting is some of the newer technology and techniques to even prevent the infections to begin with. And so one thing I saw recently at a conference was this coating on an implant that was just approved by the FDA, and it basically has these really tiny spikes on it. So tiny that you can't feel them, you can't see them. We're talking nanometers here. And those spikes actually puncture bacterial walls, and so the bacteria can't survive on it. But it does nothing to human cells. So it's almost like a mechanical antibiotic property. Like I said, it was just approved by the FDA. So we're going to start seeing these implant companies, that we use for our total knees and total hips start doing all kinds of things with coatings and how they, structurally change the implants to reduce the chance that they get infected. And I think that's where, most of the excitement and most of the total joint surgeons are going to say this is what's going to move the needle. There's a lot of technology in total joints, and I might be biased, but I think the total joint world has the, in all of orthopedics has the most technology behind it and driving it. Part of that is because it's, the need for a total joint is so common now. You look at Medicare's single biggest expenditure on a yearly basis, and it's total joint replacements for the most part. And it's only going to grow. As my parents age, and the boomer population is getting older, and they want to remain active. So more and more total joints are going to go in, and so you've got to figure out these things. You got to figure out how to get these implants to be more stable. You got to figure out how to reduce the infection rate, because otherwise, you're going to start seeing a lot of all those other problems that occur with total joints as more and more of them are put in. So
yeah, it seems like there's a lot of reasons to get it right that first time. Even avoiding more and more expenditure with the life expectancy going up, as you said, it's just gonna get more and more common. What kind of stuff gets you excited every day? Is it helping somebody feel better? Do you love that part of it? The problem solving? What kind of gets you excited to come in every day?
The one thing I love about total joints and orthopedics in general, to be honest, is that there's a problem, and then we fix it, and then the patient generally is immediately better, right? And so a lot, again, I don't, internal medicine wasn't for me, but there's a lot of, well, here's just medication that you have to be on indefinitely, right? Yeah, and so you maybe don't see that immediate gratification from the work you did, but I'll say, especially for total hip replacements, the 97% satisfaction rate. They're the top two procedures performed in America are cataracts and total hips, and the total hip was named the greatest medical innovation of the 20th century. And so, you see these people who are hobbling around with this terrible hip pain, and they're miserable. It's affecting their relationships. It's affecting their sleep. It can cause depression, and people have to stop doing the things they like to do that keep them happy because of the hip pain or even knee pain. But and then you put that total hip in, and it's from day one, like, oh, that pain's gone. I feel so much better. I can do everything I want to do. And of course, there's rehab and recovery involved, but that arthritic pain, that disabling pain is gone, and it's replaced, with the surgical pain, but that gets better. That improves rather rapidly. And so, that to me is like when you see the patient in clinic and they come in and they're like, Doc, did you even do surgery on me? Like, it feels so good, so different. I'm so much happier. I'm getting sleep. My relationships are better. That to me is the win, right? That's what you do it for. And as the revision guy, there's patients that come and they've been kind of kicked down the road by all these other surgeons or ignored or said, you're too old, you're too sick, or I don't have the skills to fix that. And then, they come to me and, if I am able to provide the services that they need, then, that some of those patients are the happiest, right? Because they're not even looking for, 0 out of 10 pain. They're just looking to like, can I get out of bed?
Right. Can I
move
around a little
bit?
Yeah.
Right. And so when you give them something that's functional and restores their mobility, and you forget, like, as humans, we're meant to move, right? You don't move, bad things happen, right? And reduce life expectancy and all that kind of stuff. And so to get people up and get them moving, like, that's the win, right? That's the goal. And so a lot of these patients, they come from all over, hours away, and we're able to give them, a very specialized surgery. And then you see them in clinic and, they're just beaming and they're happy and they want to talk about, all these things and things they can do and they haven't been able to do for so long, and how we, our team took care of them. And I should mention, it's not just me, right? It's the nurses, the OR staff, it's my clinic.
Even goes to like the physical therapist.
Absolutely. Yeah, good point. The physical, I can't do my job without them, right? And so it's all a team effort. And I mean, I think that what gets me up going is that it's, you're really drastically improving some people's lives, like, almost immediately. You do something that they didn't think was possible. I mean, they're your best friends, right? Yeah. so I think for me that was, if you go back to the point about, in medical school, how'd you know it was orthopedics? I mean, that's part of it, right? It's that immediate satisfaction of doing surgery and helping someone's life. And that can be said for the ortho trauma guys. I mean, they come in with like a broken femur, we fix the femur, they're like, oh my gosh, it feels so much better. Like, yeah, because your bones aren't moving around, right? And so hand surgeons, sports surgeons, rotator cuff tears, all that kind of stuff, you fix those guys up and they're feeling better. They know that you did something good for them and they're very thankful. So
yeah, and then you also see cases where, like, guys for whatever reason didn't get a surgery. And it's like, if it's something with the shoulder, they can't lift their arm up, or it can get bad.
It's hard, like, if you've never had an injury yourself or, a joint problem yourself, like, you don't truly understand it until it happens, right? And I say that as a guy who doesn't have a total hip or a total knee in, right? But from an injury standpoint, like, if you can't, like you said, put your arm above your head, immediately you're like, well, now how do I wash my hair in the shower? Yeah. How do I just do, like, basic hygiene functions? How do I get, like, a plate out of the upper cap? It's just like these little things in life. And then you realize that if you're like an arthritic patient who can't do some of these things, and it's indefinite, right? It's not like, oh, I just got to wait 2 weeks until it heals and I'm good. Well, now you can see where the depression and kind of the really quality of life diminishing aspects of some of these orthopedic injuries and diseases come from, and you're like, yeah, I get it.
Yeah, it's so amazing that just like how much technology we just progressed with those types of things. Because if you think way back, it's like that was it. No surgeons are going in there, and if they do, it's like you got a peg leg or whatever from way back when.
Oh yeah, one of my favorite things is I love reading about these books about the history of surgery. And there's some really good ones out there, and it's interesting because a lot of what we do in surgery is there's these instruments that have weird names to them, right? Or these procedures that have weird names associated with them. But then you read these books about the history of surgery and certain surgeons and procedures, and you're like, oh, that's like named after this guy. He was 1890s in Scotland, and he was doing this type of amputation, and now it's named after him, right? So, but you realize, like, yeah, those guys. I mean, they call it an operating theater for a reason, right? it was just a patient lying on a table and 100 students standing around watching them, right? There's no sterility in that, right? Like, and so you look at where we've come, right? And now we're in these, these high tech, operating rooms, which, have all these, laminar airflow, negative pressure, or, positive pressure for most of them. The robots are in there. You have TV screens that are hooked up to X-ray machines that are, and it's crazy, right? So, yeah, to your point, think about where we came from and what we do now. It's pretty wild.
After, the lights go off and you're just at home with the family, what kind of stuff, how do you kind of unwind? Like how do you manage that work-life balance?
Well, great question. So it's funny you bring that up because a Wall Street Journal article just came out a couple of weeks ago that caused quite a stir that there's a difference now between new physicians and older physicians where there's, new physicians are looking for a work-life balance and older physicians, not so much. They just were working, right? So it's like kind of this generational difference. But for me, it was definitely about work-life balance. Part of the reason that I came to Quincy, which I get asked a lot because I don't have any family here. I don't have any connections. I went to med school in Chicago, but that's 5 hours away. So, but for me, it was work-life balance. And some people argue like it's not really a balance. It's just work-life management, right? You're never really going to be fully balanced. You're just going to manage the competing interests in life. And so, for me, I wanted to come to a place where I am needed, that I can do the surgeries I am trained to do. And that I'd be an asset to the community and the health system and the hospital. But also, I have a wife and 2 small boys, 1 and 4. And so, for me, it was about where do I go where I can get fulfilled from a work standpoint, but also still maintain that balance with the family and be around, And so, I go home. I try to leave all my work at work except for when I'm on call. I don't like to be doing notes or putting in orders and stuff from home because, when my boys see me, it's, Dad's home, let's play time. You know what I mean? So, that's my unwinding right now. I like fitness too. I like to run and work out. And I was a swimmer growing up. I haven't swam in a while, but, just being active in that way, grilling out for the family is always a fun time. But, I would say the way I unwind is being with the family, and that's kind of where you kind of reset and kind of fills the tank, that, you can get a lot of wins in clinic and the OR, do a lot of good work, have a lot of happy patients, but you still need that, something outside of work to fill that tank. And for me, that's family. And, my wife's been with me through residency and the Air Force and fellowship. So she's a saint, works full time herself. So I'm thankful for her help, and which allows me to be, successful in work, because I know that, if I'm late in the hospital, if I've got a call or a late case, that, she's capable of taking care of whatever needs to be taken care of and allows me to help my patients. So, but yeah, I mean, family's great. I love, hanging out with the boys, and they're into sports. And so everything's a ball to them, anything that's circularly shaped, they're going to be trying to throw around, and just being active, which is good, keeps me active.
Keep away from the windows.
Yeah,
TVs,
right. I know, exactly right. So, yeah, that's the thing. I don't have girls. I grew up with 3 sisters, but people always talk about the difference between boys and girls, and the boys, you gotta have your eyes on them 24/7. It's just if boys are playing and they're quiet, like something's wrong, right? Like you better go check on them. So. But it's been great, and they've loved the move to Quincy. Everybody's very happy in the family, and they're really adjusting well. So it's been great.
Awesome. Well, thanks, Dr. Moroze. I had a good time chatting with you and learning a little bit more. And it's awesome to hear those stories of patients getting better and just make the difference that you guys make. So
yeah, absolutely. And thanks for having me on, and really enjoyed it as well. And hopefully we can do it again sometime.